Continuing, the risk factors are also surgeon related. All of us must evaluate what our capabilities are, how good our team is, and we should take up patients which we can handle from beginning till end. A high risk patient in a smaller center or with a less skilled surgeon is much bigger risk than a high risk patient with a highly capable surgeon in a bigger institution. So the risk factors are also institution related. The hospitals which are more vulnerable are people practicing in periphery where the backup is less. There is a one-man nursing home or a hospital run by a couple. More violence occurs in such hospitals because one person cannot be always available. He doesn't have a backup. Once he's away for some place, the risk factors go multiple if something goes wrong in his absence, because every small hospital or nursing home cannot afford to have a backup manpower primarily of the same skill as the surgeon himself. Then these are minor risk factors which I have said: disease related, the risk factors of the patient, patient's body related, surgeon related, and institution related. Now there are 4 risk factors which are more important, which I will enumerate as major risk factors. These risk factors are attendant related. Now let us compare, for purposes of comparison, if we have 2 different kinds of patients. One who has educated people who can understand the problem. Second patient has got couple of attendants which are more likely to create problems. Though, who are those patients who are more likely to create problems? Dr. Nidhi, if you are online, please click. Please write a comment on the screen so that you can be taken in. Now, which attendants with the family or the patient are more likely to? I will try to share with you a formula of P. Always be careful regarding P. When I say P, that stands for politicians, that stands for powerful people. When I say powerful, that means those who are in administration. You request to be in the broadcast, then I can click better. So when I say P, that means the police, the politician, the press, and when I say P for powerful, that means all other government officials. They may not be able to help you, but they have a higher level of expectation and a higher level of nonsense which can upset you for your next coming 1 week. So these are people which I would label as handle glass with care. I hope I am not quoted anywhere. Now these are the people who are more demanding. They need to be given more counseling. They need to be counseled every day. And whenever you are counseling such people, you need to You need to tell them about all the risk factors, and every time get them morning, evening detailed discussion, and take a consent, preferably record everything on the file that all these things have been told to the son. And okay, so that's something about attendance. Now when there is more number of attendants, even very gentle people can create a lot of trouble. Today's topic, we are discussing violence prevention in hospital practice. And now the next important factor is availability. When something goes wrong, when there is a complication or when there is a unexpected delay. What is a complication? Whatever the family didn't think would happen, if it happens, it is a complication. If the patient was mentally prepared following peritonitis that this gentleman will have fever for 5 days, he may have wound infection, his wound may require suturing again. Now that is not a, then if the family understands that, then that is not a complication. Availability, whenever the things go wrong, you need to, a person, when the main surgeon is available on the scene or is number one which is available on the scene, it is easier to explain to the patients and the attendants and the family that this is a complication, because people have come all the way, say 300 500 kilometers away, a lot of money. Welcome. Hello, welcome.
Hello.
Yeah, welcome. We are continuing the Indian perspective of problems. Once I finish, then we'll get you for why such things happen less often in United States, right? Okay?
Yes. Yes.
Yeah. So availability is very important. And the next point in Indian perspective is finance. When a sick patient is admitted and after a couple of days following an unexpected complication, when bill goes up, the family who came with an expectation to spend amount X, when the amount becomes X square, the problems go up several times. Now, this is an unexpected healthcare burden on the family, and the family becomes more irritable. When they talk to the doctor doesn't give time. Most of the places, the doctors do not have control over finance. So the finance department keeps pushing the family to deposit more and more money. Majority of our patients who come to healthcare are not insured. Now here, a volcano disrupts the day the old man conks up. Then that violence is created as a revenge, because not only they have lost the patient, the bill has gone several times up. The single most important thing in Indian perspective is communication. We convert a MBBS boy within 3 years into a surgeon. We convert a surgeon into a GI or a cardiovascular surgeon in 3 years. But what time do we teach him how to talk to the family? When do we tell him how to communicate with the relatives? How do you talk to the patients? Probably never and nowhere. That era is diminishing when we had old-timer teachers, observing them and working with them, people learned how to communicate. Now, surgical teachers in Indian perspective is a vanishing commodity. This community is going down in their percentile every year. And the bright and young boys are not interested in teaching because the government is not looking after the teachers. Hence, the new breed of doctors are howsoever technically bright, but socially and worldly, they are not as smart as the generation before. Some of them may be smart communicators by inheritance, but there is no structure or protocol methodology to train the boys of today how to communicate. So one of the single important factor is communication. Number two, the people who know how to communicate do not visit the ward. They do not give time. So we have two kinds of people. One, who go to the patient periodically, don't know how to talk. Number two, people who know how to talk, they make rounds on Monday, Thursday, and maybe Saturday. What about the families who are waiting, the patients in ICU on adrenergic support, and the families waiting out, praying, and waiting to see a face for which they have come all the way, some 500 kilometers, in search of solace and relaxation and hoping that their guy will get well. So these are the risk factors. Now, why I have brought this topic today is I'm sharing this paper from Lancet, May 3rd, day before. The paper of the Lancet gives an article on increasing violence in Indian perspective for doctors. Now, this is a world-class journal which is highlighted. I would like to share with members the data of Lancet. As per Lancet, 40% of the residents in 2016 in India faced some kind of violence in tertiary care hospitals. As per IMA data, 75% doctors in IMA face some kind of verbal or physical abuse in their lifetime. Junior doctors are more likely to face the violence than the senior doctors because they don't come on the scene when the patient is sick. And something very important, 75% of the bright kids who get into government medical colleges, they think twice before joining medicine today. 70% have some kind of fear at back of their mind regarding violence in India. And that's how the bright brains, they get lost to the Western world. Whatever communicator I am, and I have been a motivational speaker for doctors at several platforms, even I have faced some kind of violence, well, if not physical, the verbal, and it is some cool head which probably saved my life a couple of times, the presence of mind. So with that background, we will start the discussion. We have with us our daughter, Dr. Sharma Maheshwari. Welcome. She is
Thank you.
Associate Professor of Breast Rad in Cleveland Clinic, Ohio. She has been in surgery for a year in her internship where she has directly faced the public and the patients. You tell us, Nidhi, why you don't have such kind of problem in the United States, or they are minimum. Yes, over to you.
Thank you so much for having me here, everyone, today. Yes, I would definitely like to share my perspective. I have
Bit loud,
trained and then
bit loud.
been. I have trained and I have been at the Cleveland Clinic for last 12 years now. So I would like to share my perspective. Is that loud enough? Can you hear?
Yeah, a bit more loud will be better. Yeah,
Okay. So there are around 5 points that I want to discuss. The first one is finance. The finance issues in India and United States are different. A majority of our patients are insured when they come. So insurance is not a problem. For another sect of people who are not insured, there are a few different options available. The first one is called Medicaid, which is for poor people. So if they have an emergency situation and show up in the ER emergency room, they will be covered by the government. So they know there will be no financial issue there. Then the last president, Obama, came out with an Obamacare Act, which is a subsidized insurance. So people who cannot afford the expensive insurance, it's a very subsidized, minimal monthly amount that people have bought. And the third is Medicare, which is for everybody who is a citizen over age 65 and their health issues are covered when they show up in a hospital. So insurance is not an issue. So financial burden is not as soon as the patient steps into the door of a hospital. Everybody tries and gets the best care possible in most situations as soon as possible. So healthcare is not delayed. Second thing is manpower and facility. There are, I feel, lesser complaints in our health system because people are adequately manpowered. There is certain number of doctors needed per.
bit loud, please.
There are certain number of doctors who are needed for a specific number of patients. So if the hospital census is more, they will have more on-call physicians to cover so many patients, and they will increase the number of nursing and ancillary staff. So there is always enough number of doctors and paramedical staff available um, to have enough manpower around so that the patients and their families feel comfortable and all their questions are promptly and adequately answered. Also, all of our manpower, at least at the hospital I work at, gets a training, a mandatory training called respect. This is to respect your patients. This is to be nicer to their families. This is how to talk well to your colleagues and to your paramedical and other ancillary staff who work in the hospital. Everybody gets this respect training. I think that minimizes the number of complaints because just upfront we are spending enough time with the patients and their families explaining everything in detail. Thirdly is informed consent. We have moved on to electronic informed consents for every single procedure, from a small biopsy to a major surgery. Enough time is spent with the patient, explaining them over and over as many times it takes for them or their significant other or their family to understand what's going on, what to expect, risks, complications, and the details stepwise, and what precautions to take before and how will be aftercare set up after the surgery. So that is important. If after passing all these steps, if finance is not an issue, manpower, facility, explanation, all of those were met, and still somebody has a complaint, uh, most practices have an ombudsman office. Ombudsman office has people working there called ombudsman. These are the people who triage complaints of patients and patient families to as a moderator. They are not partial to the doctors or to the patients. They are a third person party who is not a law enforcement agency, but they work for the hospital system to answer and find out and clarify what exactly happened in the situation for which a complaint was made. So I think that also helps to triage a lot of complaints that come through from patients and patients' family. They pacify them by telling, we discussed this with the physician team. They are sorry, or this is the physician's explanation why this happened or why you felt like this, and it will not happen again. And that helps a lot of patients and families if they felt they were not answered in a certain situation or they felt not taken care of enough. Uh, Thirdly, law and order. I work for Cleveland Clinic. We have our own Cleveland Clinic police system. Cleveland Clinic Police is the third largest in the state of Ohio. So, as our first response system, we have Cleveland Clinic Police, which is at every building, everywhere, all the time. We have numerous police officers. It's a pretty large force. It's the third biggest in the entire state. After that comes city police. If there is actually a case of harassment or physical abuse, verbal abuse to a doctor, we can call the police right away. And law and enforcement is so strict that the patient rest be ensured that they will be behind the bars within an hour, 2 hours or so after the complaint is lodged. So the law enforcement is so strict here that patients fear to get to this last step of actually punching a doctor in their face, because we have taken all these other steps before to prevent this final step. But if it happens, they go to jail, and there is no excuse or saving. It'll be a court case, and they will present from the jail to answer. Obviously, if it's the patient punching, they will be given the immediate medical care needed, and then police gets involved. But usually, it's one of the close family members, and the police takes care of them. So that's my perspective of how we try to prevent reaching this situation. And if you finally reach this situation, it's the law and order and strictness that prevents. Thank you for having me here today.
Okay, thank you. Thank you for
Any
being
questions?
with us on weekend, early morning. Now, as we get back, now how the perspectives are different. Finance is never an issue. The counseling is very good. The manpower is available. All the infrastructure is available. And on top, the law enforcement agencies are working around the clock so that after all precautions, still no mishap happens. Now the point which I want to emphasize today is, in Indian perspective, people will never be insured, number one. Number two, the law and order will never help us. So how are we going to prevent it? So one important thing is counseling. And the second point is smell the rat. If you are thinking there is somebody who is likely to create trouble, the best solution is, if you are in a smaller unit, don't take up such patients who are likely to create trouble for you. Right? So, anybody else, please, from LGS, anybody who wants to put up his views, please send me a request. I will get him on the screen. So, in my conclusion, we need to, number one, communicate properly. Number two, smell the rat. Number three, look into your own capabilities, your facilities to exemplify. A professor and head of a big medical college may be doing excellent high-end surgeries on 31st December. On 1st January, he retired and joined a tiny nursing home. Now, he doesn't have the team, he doesn't have the retraction luxury of 4 people, and he's likely to commit a mistake. One of the famous example is chief of a big hospital. After retirement, when he joined a small nursing home, he wanted to ligate the internal ileum, but accidentally ligated external ileum. Now, this cannot happen because he was not capable. Probably he did not realize that he is now stuck with a smaller team, with lesser relaxation, with lesser retraction. So he is likely to do the mistake. So let us know where we are wrong. So let us take cases which are meant for us, to within which are meant for our infrastructure, which is meant for our team. Take only as much. Even the best district session judge doesn't take up a case of High Court, and the best High Court judge does not take a case of Supreme Court. So is the classification of patients who are coming to us, and so is the classification of procedures. It is not sensible that you see a case in the workshop you saw yesterday and today you start doing because you have seen one. That's not the right approach. And that is where things go wrong, when people jump beyond their capabilities. One important thing, it is a reaffirmation of what I said. It is reaffirmation of what Dr. Nidhi said. Is I attended a workshop for 3 days. Last week, we had a very bright speaker, Dr. Eric from Hershey, and he showed a case where they operated 9 times a lady with hernia. So somebody from the hall asked, "What about litigation to you on this case?" Then he said, "Each time I operated in pre-op counseling, I spent an hour with this girl." So he said, there is no litigation on me, because he explained the patient. He also said, normally he sees one patient once a day. But if something goes wrong, he said, minimum twice and maybe as often as needed. So that affirms, number one, communication, number two, availability, number three, assessing your capabilities. Do we have some member who is keen to contribute? Is welcome. Dr. Sunil Singh would like to come. Dr. Gambhir, what are your opinions? Please share with us. So, we are waiting for you, Gambhir. Any questions, please? The net connectivity is poor today, and since there are no more questions and comments, I would like to close the talk on this only. I will welcome any questions and queries on this topic. I would happily like to reply whatever I can, and will leave it to the house what I cannot. Okay, bye everybody.